Healthcare Hospitals for HS 375 by Jacob Nelson, Cheney Mobley, Phil Miller, Callie Hayner, and Sarah Harding. A hospital is defined as, according to collinsdictionary.com, as a place of shelter and rest for travelers, and a charitable institution for providing and caring for the aged and infirmed. And this is considered an obsolete definition. Today, it is considered an institution providing medical, surgical, and psychiatric testing and treatment for people who are ill, injured, pregnant, etc., or an outpatient or inpatient, outpatient, or emergency care basis, often involved with public health programs, research, medical, education, etc. So the history of hospitals goes back quite a ways. It goes back to the Mesopotamia and Buddhist monasteries in India and Sri Lanka. They're the first ones to, well, actually it's debatable whether or not they're the first, but they are the first to be said to have had dedicated hospitals. In Sri Lanka in the 9th century, they are the first to have had actual structures for hospitals. In 400 AD, monasteries were established. The religious trying to figure out what I need to say. So religious institutions had a huge influence on healthcare and hospitals. And so in the 1400s, the hospitals were built in a cross shape. And in 1524, the oldest hospital in North America was built. And at one point, all hospital beds were faced towards an altar in an open ward. And that was actually before the cross shape was built, which, yeah. And then, and they were really aimed more towards the poor and the, those who couldn't afford in-home hospital or in-home doctors. And then in 1842, London's first pay hospital was opened. You can go to the next slide. Let's see. So in 1910, Mount Sinai's Hospital in New York City was built. In 1935, Beaujont's Hospital in France was built with 13 floors, and they started building upwards instead of out because it took less time to get to the different wards. They had, at one point, they had 100 bed wards, which proved to be not as great as they had hoped because they were not as sanitary as they needed them to be. And they, once they started having pay hospitals, they started limiting the amount of people that they could have in each ward because people weren't willing to pay to be in such big wards. And so they started limiting them to the 2 to 4 bed wards. And Florence Nightingale played a huge role in, they call them Florence Nightingale wards because they weren't as effective at keeping people alive and keeping them safe. So you can go on to the next roll. So originally, hospitals were really focused on helping the poor have a Christ. And so a lot of the patients were they were aimed more towards helping them rather than curing them. They wanted them to be closer to Christ, and so one of the sites I read said that they would take their confessions before they would allow them to enter the hospital. And so I kind of found that a little bit interesting. So yeah, anyway, next slide. The nonprofit roots of the hospital was interesting. According to the textbook that we read for the class, most of our medical organizations, hospitals, doctors' offices, etc., have the roots and beginnings in religious organizations. And it says the roots of U.S. healthcare run very deep in the soil of religious or faith-based organizations. The Roman Catholic Church and its various orders sponsor many of the earliest hospitals, clinics, and nursing homes. Likewise, the Seventh-day Adventists, the Baptists and Lutherans, and the Mormons all founded hospitals and charitable healthcare services. In the United States before 1965, all hospitals were nonprofit. And until 1965, we didn't have any hospitals that were profit-based. You can go to the next slide. And so it was in 1965 when Dr. Thomas Frist started the very first for-profit in Nashville, Tennessee. And it was also in 1965 when Medicaid was first federally mandated. So I thought that was a little interesting.
So when we talk about hospital demographics, we first start with facility classification. And there's really two types. There's the public and the private. Public, you'll notice that there's substantially more in terms of number of facilities, and those are going to be found. Public hospitals tend to be funded by local, state, and federal funds. And as a result, the interesting difference between public and private is that in public hospitals, they cannot turn away any patients. Even if the person arrives with zero money to their name, they must treat and take care of those patients that come in. However, on a private institution, the only exception is that the emergency care must be administered, and then they can transfer them elsewhere. But again, due to the nature that public tends to be bigger and privates tend to be smaller in general. There's also within the facility classification, there's community and non-community. Those in the community sector are going to be all federal, short-term, general, and other special hospitals. Special hospitals include those dedicated to obstetrics, gynecology, ear, nose, throat, rehabilitation, orthopedic, and other individually described specialty services. In a non-community, they're found in any given community. The non-community organizations are part of a private sector and have the same regulations and requirements for care. The big one that we talk a lot about thus far, and I'm sure is a big topic of conversation when talking about classification, is not-for-profit versus for-profit. Not-for-profit hospitals are viewed as charities by the IRS. In keeping with their charitable purpose and community focus, nonprofit hospitals are often affiliated with a particular religious denomination, like we discussed earlier. And for-profit hospitals tend to serve lower income populations, while nonprofit hospitals tend to be located in communities with less poverty and higher incomes. For-profit hospitals are owned either by investors or shareholders of a publicly traded company. You'll notice that within facility classification that there's different categories, and something to look over in your own time is within each region, classifications are differently, but essentially there's 3 different types of hospitals, and it's all determined by their bed size in this classification, and that's going to be small, medium, and large, and depending on the region is depending on what your hospital will fall into category-wise. In addition to these other classifications, we have rural and urban. Those are pretty straightforward. Rural hospitals, I thought was interesting that really it's 19% of where the population resides, and then urban covers pretty much the rest. I did think it was interesting that urban hospitals service geographic areas defined by ignoring, defined by ignoring geographic boundaries and linking patients to a single hospital on the basis of many patterns of physician contacts. And that was found in Medicare. Within the organizations, there are critical access hospitals. The Health Resource and Service Administration definition of a critical asset, CAS, includes that are certified under a set of Medicare conditions and participation. There are no more than 25 patient beds. The average length of stay is no more than 96 hours for acute inpatient care, 24-hour, 7-day-a-week emergency care, and they're generally located in a rural area, at least 35 miles away from any other hospital or critical access hospital. The disproportionate share hospitals serve a significantly disproportionate number of low-income patients and receive payments from centers from Medicaid, Medicare services to cover the cost of providing care in uninsured patients. And there's an adjustment formula at the bottom there for your information. Some of the advocacy and representation you'll find within these are the AHA, the American Hospital Association. It was founded in 1898 and provides education for healthcare leaders and is a source of information on healthcare issues and trends. It was also a national organization that represents several types of hospitals, healthcare networks, and their patient and communities. Nearly 5,000 hospitals, healthcare systems, and networks, other providers of care, and 43 individual members come together to form the AHA. The other organization that is often referred to as the FAH, which is the Federation of American Hospitals. That was founded in 1966 and is a representation of more than 1,000 investor-owned or managed community hospitals and healthcare systems. Acute care hospital statistics. The number of acute care hospitals in the U.S. is 5,074. Multi-hospital systems and integrated networks, you're going to find that community hospitals in a multi-hospital system is going to be a little bit higher than community hospitals, or really double than with those within an integrated healthcare network.
Okay, so when we're defining the levels of acute care, the Society for Post-Acute Care and Long-Term Care defines kind of what those two are. And long-term care is for those who can no longer take care of themselves, or who need assisted living centers or facilities where they manage chronic conditions. Acute care is a branch of the secondary care where patients receive short-term treatment for injuries or illness. And there are 4 levels of acute care: primary, secondary, tertiary, and quaternary care. So the first level is primary, and this is the patient's first point of contact with the doctor, the primary care physician or PCP, and they do the initial assessments for non-emergency needs, and they also coordinate if the patient needs further care to see a specialty doctor. An example of primary care is a doctor finding a mole during an annual exam, and they take a biopsy, found melanoma, and refer to oncology surgeon and a dermatologist to take that to another level of care. And this is the secondary care. You will be taken care of by someone who has a more specific expertise in what is ailing you. Secondary care focuses on more a specific system of the body or disease. And an example of secondary care is getting referred by your PCP to see an endocrinologist to treat a thyroid disease. This level of care is one where requires highly specialized care within the hospital and requires specialized equipment and expertise. There's different levels of ICUs, medical, surgical, freestanding, pediatric and PICU, neonatal, NICU, the coronary care unit, and those other types of ICUs are part of this more emergency, higher grade level of care. And quaternary care is considered an extension of the tertiary care, but with more highly specialized and unusual cases. It's not used often, and not every hospital offers this type of care, this level of care. It's more for experimental medicine and procedures that are very specific and are more rare that you'll find these cases. So not every hospital has this level of care, but it is a part of the acute care levels. So reimbursement, the payers are Medicare, Medicaid, insurance companies, patients, insured or self-pay, and healthcare provider. The CMS, the Center for Medicare and Medicaid Services, says that it's changing the way that they pay hospitals and are doing different rewarding systems for different hospitals as an incentive for the hospital to have higher quality care. And so it's kind of interesting to read about their different programs that they do for the hospitals, but they are a major payer for the hospitals, Medicare and Medicaid. Insurance companies, they negotiate with hospitals and providers the amount that can be charged for the various types of procedures. And the procedures are often required to be pre-authorized by the insurance company before the date of service. And insurance companies notify the patient of how much they cover and how much will be the responsibility of the patient afterwards. And patients, self-pay patients are those with no insurance coverage from a company or the government, and they have not chosen to have insurance coverage and do not qualify for government assistance. The self-pay patients will usually pay full price for the medical services. They have patients that have healthcare insurance or are covered by Medicare or Medicaid, have rates with providers that have been negotiated by their insurance companies or the government. And insurance companies may or may not cover all expenses and may deem that some procedures are not necessary or required, and thus could be denied, leaving the patient with the burden of paying the balance to the hospital or provider. The patient may dispute with the insurance company any payments that have been denied, but it's ultimately up to the patient to be responsible for all the bills that are done by the provider. And healthcare provider. The provider discounts their services per the negotiated rates with the insurance companies and the government in the cases where the patient has coverage. And the provider will generally submit all costs for the procedures to the insurance company, but hold the patient ultimately responsible for the costs that are not covered by the insurance companies or the government. Oh, sorry, this is me as well. I'm sorry. So private practice versus hospital-based practices. In private practice, fewer physicians are opting to open or maintain their private practice with the high cost of overhead and maintaining staff and medical and office space. Usually it's just not worth it for them to have that, along with purchasing and having the basic equipment, and maintaining the equipment is very costly. And malpractice insurance costs are also rising and create expenses for providers to have a private practice. So they are usually go towards, when they are a hospital-based practice, they are able to focus more on the patient care and let an administrator deal with the responsibilities of the overhead, the medical equipment, and those kind of things. They are able also to negotiate regular income from the healthcare company and can focus on learning about the latest medical techniques and procedures. So it gives them a little bit of freedom, if you will, to practice medicine instead of worrying about their own private practice.
Okay, for the financial statements, we start off with the income statement. This is a statement that gives the performance of a hospital over a designated period of time. The income statement details the revenues earned and the related expenses incurred in the operation of the hospital. It's a tool. It is also a tool for management to use for departmental reports that will reflect the revenues and expenses for that department. Now we have the balance sheet, and this, for a typical hospital, it gives a snapshot of their assets and liabilities and net worth in a particular point in time. This will tell them the overall health of the hospital. It will list their current assets on the left side of the report and their current liabilities and equity of the hospital on the right side of the report. Both of these sides must equal out. That's pretty much what it's called, a balance sheet. The statement of cash flows it tracks the hospital's flow of cash and provides a detailed account of the hospital's sources and uses of cash in a specified period of time. It gives data for the current year and the previous year in separate columns to review for any changes. Accounts receivable will show the amount owed to the hospital for services provided. Total revenues are increasing. You'll want to see the accounts receivable increase proportionally. The statement of shareholders' equity provides a detailed account of the equity balance at the beginning and the end of the reporting period. The net income or loss is often the most significant transaction of this financial statement. Net income increases equity on the balance sheet, whereas net losses decrease equity. The statement of shareholders' equity is reviewed by the senior leadership and the board. The fixed asset file shows purchases of new and old equipment. It's important that when new equipment is purchased, that the old is removed from the file. This way they're not showing accumulation of equipment or historical assets and paying insurance on equipment that's no longer there. Hospital governance. The governance or governing board have the duty to establish policy, maintain quality patient care, and provide for institutional management and planning. The governing board are agents of the owners. They are either appointed or elected to their positions. This is a perpetual position, as periodically they will bring in new members to keep a fresh eye on the industry. The governing board will meet episodically throughout the year to discuss the policies in place, along with any new direction they might want to take the organization. They have 5 principal responsibilities. One is to establish the mission of the organization. They usually have a mission statement declaring the purpose and the mission of the hospital. The second one is to establish policies and procedures by which it can be managed. The third is to hire, orient, supervise, compensate, and manage the chief executive officer. The fourth is to guarantee and protect the fiscal viability of the hospital. And the fifth, to guarantee the quality of healthcare services provided by the hospital. There are 6 legislative regulatory initiatives that impact the hospital. Patient Safety Initiatives is a program of the CMS designed to improve patient care and to reduce safety issues in hospitals. The Readmissions Reduction Program is designed to reduce or eliminate patients needing further treatment after they have been discharged from the hospital. The Recovery Audit Contractors are independent auditors contracted by the CMS to review healthcare records. They are looking for errors to dispute a claim that could result in fraud. Medical Necessity Regulation states that if any patient receives services, they must meet minimum medical necessity before an insurance company will pay on the claim. Concurrent and retrospective review is where an insurance company will review that a patient actually requires treatment. Concurrent reviews occur while the patient is still in the hospital, and retrospective reviews occur once the patient has been discharged from the hospital. Quality improvement organizations work for the CMS to improve healthcare quality and efficiency. They will review patient records, find areas for improvement in care, according to the American Health Quality Association.
So hospitals thrive on efficiency. Efficiency makes doctors, patients, and the management happy. So naturally, there are organizational structures to help the efficiency of hospitals. The 3 different types of organizational structures are the traditional model, the corporate model, and the C-suite model. All these models represent the chain of command. So there's always someone that you report to. Here is the traditional model, and as you can tell, as I show you these 3 different models, they're all structurally the same for the most part, except for the only difference really is the names of what you would call the leaders or the management. So in this traditional model, there's an administrator, and as you can read for yourself, the other as it goes down. In this one, the head of the hospital would be the president, and then it goes down to the executive vice president. And this is the corporate model. The next one is a C-suite model, and I think this is the most common for most people, or the one that is most familiar to people, and this is with the CEO, the CFO, the COO, and the CNO. So many of you guys might be asking yourself the question of is there anything out there, any resources, any programs, any organizations that can help me further my knowledge and my career as an administrator of a hospital or whatever you're pursuing? And there are lots. And to name a few, I have a couple bullet points, and I'm going to read those out to you. Association for Healthcare Administrative Professionals, American Association of Healthcare Administrative Management, Healthcare Administrators Association, American College of Healthcare Executives, American College of Healthcare Administrators. So these are just a few of the many organizations out there to help administrators to be knowledgeable in what they're doing and to be prepared and helping the hospitals be efficient. These organizations provide access to research, journals, events, and conferences in their specialty, which is very helpful, and also updates on changes in healthcare services. Usually there's just an annual fee to become a member. It's usually very beneficial to become a member of these organizations. And these are our references. Thank you for watching.